All right, so I'm kind of taking from Elaine's presentation and the work we've done at the Lancet Commission on the link between hearing loss and dementia, and taking a step further from what the epidemiology tells us about the link and towards the clinical trials that Elaine mentioned we need to firmly establish the link and to orient and inform what sort of interventions can help here and whether they help. Right, so let's start by very quickly going through one of the main motivations for the Lancet Commission, which is that so we have kind of good news about dementia, which is not a sentence that you're going to hear very often, but we do, and the good news is that in the past 20 years, roughly, in the past generation, there has been a drop in age-specific incidence of dementia, or of about 20%, in Western societies. The picture may be different in other societies. But let's be clear about what this means. It does not mean that dementia is not a problem that is massively increasing, because the population is aging at a much faster rate that any of these changes is happening. So the cases are still, increasing at a very high rate. But it does mean that at least in Western societies, it appears that your risk of having, if you're over 65, your risk of having dementia at a given age is about 20% lower now than it was a generation ago. And we know this from very, very well done studies, including the CFAS 1 and 2 waves. So basically, they went through a number of counties in the UK, in England, and they went to people's homes and assessed people and found if they had dementia, and they repeated the task with the same methodology essentially 20 years later. And surprisingly, they found this drop. And if you're interested in kind of sigmoid curves that are kind of very frequent in medicine and biology generally, you will think that shows a shift at about, it's not 5 years, but 2-3 years perhaps in the onset of dementia. Right, so the question is, what happened then, and can we do more of it to further reduce the risk of dementia? So I think we all have ideas of what happened then, and for example, one of the things that happened between the 90s and now, or you have to think even earlier than that, because the risk changed during that generation, is there was an increase in education. There was also a reduction in people doing things like smoking, for example. And probably cardiovascular health and education is a big explanation of what happened there. All right, but can we take a systematic approach to the literature, to the scientific evidence, and find what could possibly help to further reduce the prevalence of dementia? So this is what we did in the Lancet Commission. And we adopted a series of assumptions for this that it's very important to keep in mind when assessing what the evidence is. So our assumptions were that the associations identified in high-quality epidemiological literature were in fact causal, were in fact, they were showing that this was a true causative effect on dementia. We pre-specified what for each risk factor, what we expected as high-quality evidence. Obviously, there were clinical trials, that's what we would take. But there weren't clinical trials except for one of the risk factors, hypertension. For the rest, mostly we went for cohort studies, which is what was available. We also adjusted by what is called commonality, meaning that people who have, for example, hearing loss are also more likely to have other risk factors of dementia, like smoking, poor physical activity, and so on. So we adjusted for that. And then our estimate of population attributional risk is based on that literature and assuming what would happen if we completely eradicated that risk factor, which may be, not possible for some of them to that extent, but it gives you a measure of the magnitude of the potential benefits. So, yes, so basically we found that hearing loss was responsible for up to 9% attributable risk. And the basis for this was 3 epidemiological studies. Those are not the only epidemiological studies that are available, but these are the ones that met those 3 pre-specified criteria, which was we wanted studies that looked at hearing loss based on pure tone audiometry. We wanted at least 5 years of follow-up, and we wanted studies that looked at incident dementia, so not new cases. So we knew that first came the hearing loss and then came the dementia, which is one of the factors to establish causality. And if we put together these studies, the increased risk of dementia with hearing loss was about double, 1.9 in odds ratio. Now, as has been mentioned earlier, the first piece of evidence that was included there was a study by Franklin and collaborators from Baltimore that not only showed that there was an effect, an increased risk with hearing loss, it also showed that there was a dose response. So, mild to moderate to severe was increasing the risk proportionally. And it was also adjusted by pretty much everything else that we could consider a major risk factor very well established for dementia, including cardiovascular risk factors, smoking, and age, of course. So that's what led to hearing loss having this up to 9% population attributional risk, which was higher than, for example, hypertension or diabetes. And that was surprising and controversial even to the members, even to us who did the analysis. If you stop and think, it makes perfect sense, because hearing loss is such a prevalent condition that if it truly induces a doubling of risk of dementia, then you multiply prevalence by this significant increase of risk, and that's what you're going to find. So the message, it's fair to say that has had a very significant impact. So we included things that people could do to reduce the risk of dementia starting from middle age and even before. And this message has trickled down. So, for example, the Journal of the American Medical Association, when they did a similar infographic about what could reduce dementia, they included hearing loss, and that we can say it's a first in this area. But let's think again about these assumptions that underpin those numbers, and the fact that we are assuming that the associations identified in epidemiological studies are causal, and that we could eradicate that risk factor. And these are realistic. Are these realistic assumptions? Well, we do have potential causal pathways by which this could happen. So, for example, we know that social isolation, depression are in themselves risk factors for dementia and are also associated with hearing loss. We also know from neuroimaging studies that hearing loss is associated with neurodegeneration, so brain atrophy, which is the closest marker to dementia. And this neurodegeneration is not just limited to the areas of the brain directly involved with hearing, it extends beyond that. So there are mechanisms that potentially could explain the link. We could say it's plausible. We also can know that some of these potential mechanisms, including hearing loss, are potentially treatable with hearing aids, but also with, as Elaine mentioned earlier, directly acting on social isolation or depression. So potentially reversible. Now, this was a nice kind of linear story, but we know that probably reality is a lot more messy. So this is an analysis of over 100,000 people in the in the biobank, UK biobank. It's cross-sectional, but it's just to give you an idea of the complexity. So pretty much everything is related to everything. Hearing aid use, social isolation, depression, they're all linked to each other. So how do we know that, and also obviously those depression, physical inactivity, social isolation are also linked to dementia. So where is the best place to act? Is acting as upstream as hearing loss the most efficient way? Is it even going to make a difference? As Elaine said, the epidemiological evidence suggests that it will, but we know that these things, that epidemiology can be affected by a number of biases, and sometimes we cannot control them all. So our view is that we do need clinical trial, we do need experiment, we do need experimental evidence. Sometimes experimental evidence in medicine, in biology, we cannot do it. We cannot allocate people to smoking or not smoking, obviously, it's unethical. But can we do a trial of what we want to do, a hearing aid in people who are at high risk of dementia? So this is what we're doing at the moment. We are focusing on mild cognitive impairment. Franklin in the US is doing a similar trial on healthy aging, people who don't have cognitive impairment. We are focusing on people with cognitive impairment. We know that people who have mild cognitive impairment, which is a label that is people who are presenting with a cognitive complaint, and their cognition is not what we would expect given their age, so it's lower, but there is essentially normal functional activities. They're functioning fine in daily life, but when you measure their cognition, it's not as good as it should be. We know that these people most of them have neuropathology. They have things that have been linked to dementia or that are known to cause dementia. We know that it's a highly prevalent condition. Up to 10-20% of people over 65 would fulfill these criteria in community samples. And we know that there is a much higher risk by more than an order of magnitude relative to people without mild cognitive impairment of developing dementia, a risk of 5 to 10% per year. Is this a missed opportunity for secondary prevention? Well, we don't have any medications to give to these people. We know that treating cardiovascular risk factors to prevent stroke is important in this population if it hasn't done so, if they haven't done so yet. But could treating hearing loss also be a way to modify this risk? So this is what we want to find out. We are running a TAC pilot trial, generally funded by Alzheimer's Research UK, and what we are finding out if we can recruit to the trial, if there are people with mild cognitive impairment who have untreated hearing loss. There are people. We know that we've done all the feasibility studies, we know they exist, but can we recruit them to the trial? And we are randomizing them to a home-based intervention where we are assessing their hearing and treating and supporting hearing aid use. We know that one of the obstacles for a trial is not just ethical of not treating hearing loss, it's also that the usual NHS mechanisms by which people get hearing aids often fail, either because they're not referred, or people don't ask for it, or people get the hearing aids and leave them in the drawer. We are trying to address that as well. And that is compared to a healthy aging intervention, the other arm, when we are referring to NHS audiology. Obviously, we cannot not treat a condition, hearing loss, but we know that lots of these people are not going to get effective treatment. And the primary outcome for this trial is simply, can we randomize, can we retain, because our goal is to do a larger trial on the basis of these results, if the intervention is successful. It's home-based intervention. We are personalizing to the person's needs. We are giving them that data logging on the hearing aids with immediate feedback to improve, to detect any problems with adherence and address them. And so basically, helping as well with reminders and integration in routine, which people with memory problems are going to find challenging otherwise. So that's where we are at the moment. A story to be followed, and just a slide with the trial team people. Thank you.